Okay, good afternoon, everyone. I see Dr. Wasserman's on and Dr. Raybridge are on. So the only thing I would think, before I open it up to everyone for questions and stuff is the incidence of the pediatric patients with the COVID having this signs and symptoms of this Kawasaki disease. So I asked Dr. Wasserman, Dr. Raybridge just to, speak briefly about it. Jeff?
Sure.
Either way, go ahead.
So there's some case reports, mostly from the city, from New York City Department of Health, of several kids who have developed Kawasaki syndrome, which Kawasaki syndrome is a inflammatory pediatric disease where they can get coronary artery aneurysms, and we treat it with aspirin and IVIG and stuff. And they're seeing some relationship to COVID where, as a result of COVID, several of these kids have developed this Kawasaki syndrome. There's not a whole lot more on it yet because it seems to be recently discovered, and it was more of a just be aware of it and you may be seeing it. I don't know, Adrian, if you've heard anything else about it.
No, I mean, other than what the Department of Health put out, I mean, essentially Kawasaki is a Kawasaki syndrome, is a Kawasaki or is a vasculitis. It's mainly found, but can technically be found at any age. It really what you see from, it's to the scene. I mean, really, the main thing is fever, unexplained fever times 5. So the to be diagnosed, among other things, a fever.
Dr. Wasserman, your connection's horrible.
I don't. Is that better if I hold it?
Yeah. So
yep.
I think, Frank, I think you have all the symptoms on your screen there.
Yes.
People can, if people are on the computer, they can see that.
Yes.
Yeah.
And do we want to discuss any of the pictures I tried to get up here? I guess there's a rash on the tongue and stuff they were saying, or pustules, or
yeah. So the other name for Kawasaki's is mucocutaneous lymph node syndrome. So kind of the name describes it. You get dry, cracked mucous membrane, strawberry tongue, swollen lymph nodes, and kind of a rash and conjunctivitis type red eyes. And again, the fever for 5 days, although you can have incomplete Kawasaki's with like 3 days of fever.
Okay, so I'm hearing anecdotally from KJ Hatsola that they're getting cases up in Monroe of this. And
they probably aren't, but think they are. But
well, they said they've taken them to Columbia and they were told that's what it is. So I don't know if it's true or not true, but again, I got a bunch of people asking me to do, to do education on it. So I guess, and it could be one case and it made its way around the, the rumor mill, but that's what, that's.
I think the New York City Department of Health put out was a case series. I think it was like maybe 10 or 11 in the whole city that they had.
Okay. Okay. Does anybody have any questions on that, or has anybody seen anything or with it? I'm sorry, I'm just trying to look up people's phone numbers that are trying to get in.
For it?
What's that?
No other symptoms. Was there any recommended treatment, or how should we be handling these cases?
Pre-hospitally, no, there's nothing special to do.
It would just be supportive care. If the patient's hypoxic or having some respiratory symptoms, you can always provide some oxygen. But in a pre-hospital setting, really, there's nothing to do. It's more of an inflammatory condition that would be evaluated when the patient arrives and treated if necessary inpatient. Is my connection still bad, Frank?
Better.
No, it's much better. I just think there's some background noise of people.
Yeah.
But
Yeah.
let me see. Can't tell who's unmuted right now.
I mean, in general, I think it's important to realize that this is still pretty rare. I mean, there's been a handful of cases in all of the city. In general, children have remained relatively well with COVID, either asymptomatic or have mild symptoms. That's not to say that this doesn't exist. I mean, it clearly does exist, but it's still pretty rare. So it's just a kind of an interesting FYI for healthcare providers just to be on the lookout for.
Question.
Yeah, hold on. Okay, somebody's unmuted and making a lot of noise, and I can't figure out who it is. But okay, so I'm gonna mute everyone, and then just Jeff, Adrian, unmute yourself, and whoever was trying to talk with the question. Okay, who had the question?
Hi.
Hi, Shayna.
Has this been seen in anything in the ERs over here, or have we automatically been getting those forward to like the city, or?
We have not seen any cases of it here.
No,
And again,
we
people
have,
have been made aware of it through the case
we have
report
not
by the
either.
city health department.
Yeah.
Got it. Thank you.
Yeah, we haven't seen any. In fact, we haven't even seen a lot of peds in general here. Most of the peds that we're seeing here are non-COVID related, like injuries. We had a bicycle accident, you know, that sort of stuff. We had appendicitis. We're not seeing a lot of COVID in general in children.
Okay. Did you guys have anything you want to discuss as far as the, you know, the capacity in the hospitals and stuff that we brought up last week?
Yeah, so I would just say that.
Yeah, go ahead.
know, Yeah, I think there's been a lot of communications and a lot of changes and a lot of things changing rapidly over the last month. And I think some people may have either interpreted it wrong or got the wrong message. Yes, early on, everyone was messaging, don't come to the hospital, stay away. It's, you know, we're going to exceed the capacity and the hospitals are overrun. So we did a good job with that, but now we're at a point where we're kind of on the downside of this plateau, and ER volumes are down across the region and across the country, and hospital capacity has improved. So that's why you saw the viral pandemic triage protocol being rescinded and the cardiac arrest protocols being rescinded. And now the message is, you know, if you need to go to the hospital, go to the hospital. The problem we have is that a lot of the public is afraid to go to the hospital because they think they're going to get COVID by coming to the hospital, right? Or that it's not safe to go to the hospital because I don't want to be there where there might be COVID people, I'll get sick. Or, so in the last couple of weeks, I've seen several cases of delayed stroke presentations where people stayed home for a couple of days first, perf appendicitis, you know, delayed MI. So we're really, when I say we, I mean the whole kind of healthcare industry is trying to get the message out there that, you know, if you have a real medical issue, do not wait at home, call and come to the hospital. So, you know, I think, you know, were you guys, not that you ever told someone don't go to the hospital or tried to discourage them, but you're honest about the capacity situation. So now I think, you know, all of us need to encourage people who should be seen to get seen.
And both hospitals
Yeah, I
have
agree.
capacity.
Yeah, both of, I mean, I know we do. I'm sure, Jeff, you guys are along the same lines. We definitely have capacity, both in the ER and patient units. We've used some non-COVID units at this point. I don't know if NIAC is doing it, but we're doing a rapid turnaround tests. We have a limited supply of rapid turnaround tests for COVID PCR. So we don't have that many a day. We have about 20 a day that we can do on inpatients. So when the patients come, we can determine if they're positive, negative, and if they're COVID negative, they go to a non-COVID floor. So a little bit.
We're doing the same. We're testing 100% of admission, same deal.
Yeah, yeah. Yeah, I've also heard anecdotal reports of, you know, a patient will come in and say, well, I called the ambulance a couple of days ago and they talked me out of coming. I don't know if it's that, you know, the EMS providers on the scene are talking them out of coming, or, you know, patients are going to hear what they want to hear. That patients are afraid to come to the ER, both by EMS and by car. When I came in this morning, there was a guy sitting outside our ER and his family was trying to convince him to come in. He had a heart rate of 26 in complete heart block, but he didn't want to come into the ER. You know, in reality, the heart issue is going to kill him before even the possibility of COVID, but these people are scared. So, you know, offering patient support and letting them know that, you know, we keep them isolated and, you know, all the rooms obviously are terminally cleaned in between uses, and, We test patients, so if they need to get admitted, we test them and make sure that they're COVID negative and they go to a COVID negative floor. So that should offer a little bit of support to the patients. And again, with the delayed presentations, patients are much sicker. Our admission rates are up a good 10% of where they are usually. So sicker patients are coming in and they're getting admitted. So, you know, do your best to convince patients to try to come in and get the care that they need.
Where are you guys with your visitor policy? Because we're still telling patients that nobody can accompany them to the ER.
That's true. That's the New York State.
Yes.
That's that New York State put forth, the Department of Health, and that rule has not been rescinded.
Correct.
you.
That's been in effect at all hospitals, with the exception of obviously a pediatric patient, right? L&D, and in the ER for end of life issue, we do allow one visitor briefly to see the,
All right.
you know, in the ER.
What about from group homes? Because that's come up once or twice also. Patients from
Well,
group.
yes, a group home, if they have an aide, if the person needs an aide because they normally have an aide that comes here, that is allowed.
Okay, thank you.
What about like dementia patients that are living? Are you living family with them?
So the way that the rule is written, it says that there's no visitation allowed unless the patient is a minor, the patient end of life, patient needs a support individual. So that would technically include, although, you know, a lot of patients are, they're demented, they're stable, they, you know, their dog doesn't know where she is, so I should be allowed to do it. So,
Yeah.
you know, that's kind of open to discussion. Certainly if it's a demented patient that's trying to get out of bed and trying to walk around, agitated, I could see how, you know, allowing a person there would be beneficial. But if it's demented and they're otherwise just stretcher and they're not causing any, you know, harm to themselves, and, you know, I'm not sure the support person really, you know.
Exactly, and our take is the same as Adrian said. Is the way it's worded, it allows us that discretion. That like, if it's someone who needs a person with them to facilitate their care, yeah, we can allow them.
So should we just be calling the hospital and asking on a case-by-case basis?
Yeah, if there's, then please call medical control.
Yep. If there's a question, but you know, the hard and fast are if it's a kid, yes. If they're if it's someone who's going to L&D, the partner is allowed. And if it's an end of life issue, then yes, a visitor is allowed. If it's something like, you know, they have a little dementia, you're not sure, whatever, call and ask.
Okay, thank you.
So just as far as the, you should know, as far as the L&D patients that are coming in. So what the way our hospital is doing it, goes upstairs by themselves. The husband or, you know, whoever the support person is stays downstairs. Once the patient is determined to be in labor and they'll be admitted, then the support person is allowed upstairs. They must remain in the room at the floor. Once the patient is transferred, their baby after transferred, they cannot stay. And that's only it's in labor. So it's in the 20 weeks and they're spotting or something, the significant other or support person.
Yeah, and same for NIAC. It's for active labor. So if they're being admitted to have a baby, then the support person is allowed. We're also, and I'm sure Good Sam's doing this too, we're testing all those L&D patients as well.
Yeah, the L&D are getting rapid tests.
Okay. Just again, like housekeeping stuff, you got to make a Zoom account and sign in so we could see your name. There's people trying to sign in with phone numbers. If I have your phone number in my phone that I could see who it is, I am letting you in, but there's some people trying to sign in with phone numbers I don't know. So I can't let you in because there's a lot of spamming going on with the Zoom conferences. The other thing is to get credit, we need to have your name on the roster. So signing in with a phone number is not the same as signing with your name. So please make a Zoom account. We have 34 people in that managed to figure it out. So please make a Zoom account. Make sure your name appears, you know, in your account, and no funny names or joke names or anything like that.
One other update, just on while we're on COVID from NIAC, is that I know many of you saw that there was a drug recently approved by the FDA, remdesivir, to treat COVID. We have gotten approval for that here, and we should have it starting tomorrow, and we will be using it to treat COVID patients that are admitted.
Same here, actually. Right now, the 3, there's a conflicting meeting going on. We also received 4,000 doses, and so we'll be able to start using it starting tomorrow. So I sign off here. I'm going to jump on that other call.
Okay.
Are the 2 facilities, both NIAC and Good Sam, also using the hydrochloroquine or no?
No, so here's the deal on hydroxychloroquine.
Yeah.
We have stopped using it. The FDA has recommended against using it. And in the patients we gave it to, we didn't see any benefit. And I can tell you that the Mount Sinai Health System has stopped using it as well.
Yeah, same here. We stopped using it. The FDA came out.
Were those patients that were like pretty far into it, or were those patients who were early into it?
Both. We did admitted patients, and we also gave it to the ICU patients, but we didn't see benefit in any of the patients.
Okay.
I'm just going to mute everybody again because people are texting me that it's impossible to hear what's going on. So I'm going to mute everybody again, although it only seems like Jeff, myself, and Dr. Wasserman are the only ones unmuted, but everybody's saying there's a lot of background noise. So I'll just mute everybody again, and then, unmute yourselves if you need to say something. Okay. So is there any other questions for Dr. Raybridge or Dr. Wasserman on anything? Or is there anything that?
Yes.
Yes, Shayna?
Will we know about the you're getting it tomorrow, right? The Perceptioneer?
Remdesivir.
Yeah, you cut out a little bit. What was the question? Will you know?
So you're getting that tomorrow, right?
Yes.
So when will we start knowing if that's helping or not? Will we know that for the next meeting? Will we know that in 2 weeks?
Well, we already know from the data that from the study that was going on in the city that NIH released that there's about 4 days shorter of symptoms with it than without it, and an absolute mortality benefit of about 3% in the admitted patients. So we know it's beneficial. We just don't know how, as more data is collected on more patients, we'll see if it's more beneficial or not. But it's the only drug so far that's been shown in a randomized clinical trial to have any benefit.
Great, thank you.
Yep.
Okay, does anybody have anything else?
I have one more question.
Sure, Rob.
I have a question.
So
let Rob go.
My question is that given what they're talking about on the news about they're expecting this to come back a little bit with releasing this, do you guys anticipate a back to where we were, and the second follow-up to that is in the fall, are you guys going to be able to gear up for that a little bit?
Oh, I think everyone knows that the people are around, out and about, being social, the likelihood that worse it's happen, and that's been shown in countries that their orders, and I think, yes, we're going to see some kind of will it be to the point where we were a couple of weeks ago? I guess only time is going to tell. As far as we are thinking that it's going to get worse in the fall. That all hospitals start stockpiling PPE. So you should be doing the same, stockpiling PPE.
We just met today, and Angel has devised a whole system. So we're going to have the same as the hospitals, which is we'll have 90 days.
Yeah. So
on
that's
hand.
actually the governor's requiring that for everyone, 90 days supply.
Correct.
So, and we're looking at some enhanced PPE as far as respiratory protection beyond the N95. So we're going to try to put some orders in for some better stuff.
And every hospital is planning, to answer your other question, Rob, about the fall. Yes, we're already in meetings because obviously we're not going to have 2 ERs again in the fall. We're going to move ahead with our construction over the summer, but we have alternate plans that we've been putting together to build additional ICU space elsewhere in the building, and anticipate a similar spike in the fall. Hopefully we won't have that. No one knows how bad it'll be, but we got to plan for that.
Yeah.
Thank you.
Internally here, Nelson is going to be heading up a planning committee, I guess, to make us ready for the next wave of this. So if anybody has an interest in serving on that, you can reach out to Nelson. But we are moving ahead with, obviously, like I said, Angel is working on stockpiling stuff. He set up a nice bin system already. So we'll be rotating. We won't just have stuff on a shelf that sits there, and then when we go to use it, the elastic is all dried out. So we'll be rotating stuff, throughout the system so that it gets used, and we'll be then replacing it with fresh stuff. So we're working on a whole system so that we'll be, in good shape if and when it happens again, like we were this time around. And the county is starting slowly to start distributing stuff. The problem is that they give you a different type of N95 mask every time. And obviously there's fit testing issues and stuff like that. So, but we're going to try to, whichever one we have the most of will be what everybody will be fit tested on. And if we can get the respirators in, then, it should be a non-issue. Okay, does anybody have any questions? Ray, do you have anything? I know you're on.
I have a question, Frank.
Yes, Joe, I'm sorry.
Going back to the Kawasaki, in the unlikely event that any of us up here encounters it, is that something that they want us to just bring directly to like a higher level center, like
Yeah. So only if you have a known diagnosed case, and I mean not diagnosed by like EMS, but like actually, diagnosed by their pediatrician or something like that, and it's known that it's Kawasaki, then yes, they should go to a tertiary care children's hospital because they're going to need treatment that can't be provided in a community hospital, and they're going to need monitoring, and they may need, they need pediatric cardiology, and things that I can tell you we don't have at NIAC. I don't think Good Sam has it either, but they should go to like Westchester or another children's hospital. But if it's, they have a rash and someone thinks it might be that, then no, they don't necessarily have to go directly there.
We agree. I agree.
Okay. Anybody have anything else? Okay. Nelson, you have anything? Ray? Okay, I'm not sure that.
No, just to put this out there, the committee that we're working on has to be, I need people from both mobile care and RPS to participate in that. So I just wanted to make sure that that was clear.
Yeah, that's going to be important. We really want to get field input. What your experiences have been. What could we do better? We want to put a game plan, if you will, together for. Hoping we don't get a second wave, but if we do, we really want to make sure that that we have our ducks in order. And the input and experience from the guys in the field is going to be very, very important for us to modify our plan going forward. So those of you that are interested, please get in touch with Nelson, and we'd like to get that started sooner rather than later. The other thing too, on a good note, is Medic 3 and Medic 5 vehicles are in. They should be in service in the next day. They were in service. I think Lieutenant Greer got a little nervous with his, so we sent them back to make sure everything was perfect, and it's all perfect now. So those vehicles will be on the road in the next day or two.
Marco has her dog here.
Okay.
God.
Okay, does anybody have anything else? We're good? Okay. Thank you very much. And I guess this seems to be popular, so I'll work on setting one up again for next week. Everybody stay safe.
And just everybody, please stay safe. Make sure you wear your mask and your PPE. And if you have any issues at all, please don't hesitate to get in touch with a supervisor so we can correct it as soon as possible.
Okay. Take care.
All right. Thank you.
Bye. Thanks.